going to review the current state of primary care. What is this PCMH? I'm not going to really talk about how to implement the PCMH because that's a whole other topic that physicians are interested in. There's NCQA accreditation, which I thought was pretty onerous until I looked at the Joint Commission regulations for a medical home, and NCQA looks like a chip shot. So we're not going to talk about that. And then I am going to talk about House Bill 198, which is really, I don't have slides on that because there's stuff unfolding on that on a weekly basis. And so current state of primary care, how many people in here are affiliated with practices that are either accredited or in the process of moving to a patient-centered medical home? Okay. How many people are familiar with the concept or heard about it, read about it? It was in Newsweek this week, so okay. So that's, just to give you background on me, I work a lot with residents and medical students. I talk to them a lot. I see what they're thinking, what they're doing. I was at the hospital this morning making rounds, and actually went to medicine morning report. And it's interesting to talk to them and what they envision, is going to evolve with healthcare. As far as the current state of primary care, I thought I'd start with just the current state of healthcare. I was going to bring the newspapers from this week. I checked the dispatch this morning. There was nothing on the front page of either the local or the main section germane to this. But Medicare running out of money by 2024, I thought that was good. That was a couple days ago. I'm actually more worried about that as a patient than I am as a provider, okay? I figure. And the 12 years isn't that far away. I mean, I can remember when 1984 seemed like a long way away, or 2000. So 2024 is kind of next week, I think. And so that's one thing. You saw the article about an appendectomy can cost anywhere from $1,500 to $180,000. I tried to explain that to some non-medical people, and I was unable to. Newsweek, this week's issue about primary care and the state of primary care, and there's actually a quote in there that it takes the primary care physician 23 seconds to interrupt the patient. Actually, I've been quoting 18 seconds, okay? So that's actually a 5-second improvement in the amount of time that it takes us to interrupt the patient. So we spend twice as much money as any country in the world on healthcare on a per capita basis, but of course we're getting best results. That's why we are the top-ranked country in healthcare, kind of like Ohio is #1 in healthcare for our citizens, which is not true. So those are just kind of some national. 4 to 6% of all healthcare expenditures goes to primary care physicians and clinicians. I find that personally depressing, okay? Because all the physicians in the room just do the math. There's a lot of stuff you just have to do the math on, and we'll get to that. Stress in primary care. I did go to my office today. My charts go electronic in 2 weeks. I'm so excited. Next gen, Mount Carmel, 4 Mount Carmel hospitals go live this weekend with a hospital system, Genesis. If your life needs to be perked up and you feel that you just need a boost, I would stop by one of the 4 hospitals on Saturday and just see. Well, I was there this morning. It's kind of the feeling is between dread and doom. Okay, that's where I was. It kind of reminds me when you're watching to see what the tornadoes are going to hit. When the news is on, and you're looking at the street maps, and you're going like, oh, I don't know, do we go to the basement yet or not? It's that same feeling. And so we go live, and I'm going to talk about how important I think that is for a lot of stuff. But 78 million baby boomers in the pipeline. The first ones just turned 65. They're all in perfect health. I just want to assure you from my side that they are buffed. And they're estimating 40 to 60,000 primary care clinician. And when I say physician, I'm on the faculty of the nursing school. I work with nurse practitioner students from Mount Carmel. So it's really clinicians. It's going to take a village. It's going to take all hands on deck to take care of this tidal wave. And so that's the projected number. Our procedure-oriented payment system works against primary care. Like I said, 4 to 6% of the money outlay. 17% of the gross national product is healthcare related. The public talks about that. When I hear that, I say, well, on our side of the coin, we call that income. So when you start talking about changes, it gets exciting. The appointment times are long. There's been expanded coverage but not access necessarily, and I'll get to that a little bit. And 40% of family physicians consider leaving their practices in 2010. There's very similar data for general internal medicine. And so, some quotes on this, Director Moody talked about the Commonwealth group, it's the payment system, stupid. Okay, that's one of the quotes that kind of goes with what's happening. Dr. Winslow's quote, which I'm sure he stole from somebody, but he uses it, it's you get what you pay for. And as a medical student so eloquently put it in my office, you must really love what you do to put up with this crap on a daily basis, okay? So I think that's the quote that I will leave you with. And most primary care physicians love what they do. I mean, it's the patients that you know, the continuity, seeing them through their ups and downs, but not every day is as good as others. I like this slide. This is from a study a few years ago. You need 21.7 hours to do what is needed for a panel of 2,500 patients. That's probably too big a panel, it looks like. They're now talking about 1,800 to 2,000. But that's still a lot. And what I'd like you to look at is the preventive services. You were talking about wellness in the primary. We don't do prevention. I mean, we're strictly defensive. We are trying to get people taken, we do disease care. And that prevention really is just snuck in on the side. You just don't have any way to do it. I saw a lady yesterday, probably has a torn cartilage in her knee from a stumble. But I noticed she was due for her, we have what I call the Mount Carmel, the Metro West trifecta, which is diabetes, hypertension, hyperlipidemia. All one word, 34 letters, okay? Looking for a code for that, but so I wedged in her labs that she's due for. And all the physicians in the room, you look at the lab, well, it's been a year, you need to have this updated. So the prevention is really, really being left out. And hopefully under the new system, that will get better. We get these report cards from the insurance company every year, what we're terrible at. The latest is glaucoma screening. I am now terrible at glaucoma screening. That's an eye disease for any of you that are wondering about that. It's just worked in, we work it in. And so, just some data, there's a dollar figure that you can assign to a lot of this stuff. This is an Indiana study that almost 20% of hospital people get readmitted within 20 days, or 30 days. I mean, you can actually track what does a hospital readmission cost. And those are the diagnoses. 17% of Medicare hospital payments nationally involve a readmission to the hospital within 30 days. And there's data on heart failure patients that half of them aren't seen within 30 days of a admission to hospital, which is why heart failure clinics are popping up to try to make that better. It also helps that Medicare is not going to pay for a heart failure readmission. That was a little impetus for some of the hospitals to suddenly create, heart failure clinic follow-up. But there's readmission rates at adequate primary care. I'm the point you don't even need a good doctor. Okay, just a doctor. I mean, just somebody that can yell at you about your weight, you need to quit smoking, what's your blood pressure doing. It helps if they're good. But what are baby boomers looking for? Better preventive care, close personal relationship with doctors, and enhanced services and access. 15,000 people turn 50 every day in the United States, if you do the math on that. And again, perfect health, that's what really helps. But 8,000 turn 60. The fastest growing age group on a percentage basis is the 85 and older. And that's the group that's, I have patients turn 100 routinely, which I go to their I tell them I will go to your 100th birthday party if you serve liquor. Okay? And so you go to that, and my wife goes with me, and it's like, well, you must really be a good doctor. And I go, trust me on this one, when you turn 100, the doctor is just an observer. Okay? We're not good, we're just part of it. I'm just excited as you are to be here. I have a patient who lives at Mayfair Village up on Hayden Run Road, for those of you who are close to Bravo, is right across the street, June 8th. There's a tunnel actually under Hayden. So I'll be there. I should go. Now then there's pressure on her to make sure she gets to be 100. Okay, the family's calling, mom's got a little cough. Is that what they like? She'll be okay. Just serve liquor. Okay. So what we need is a new direction. The status quo won't work. We have milked the status quo tweaked it, primed it. We can't see any more patients. You can't work any faster or harder. We just can't do more procedures. I mean, the procedure guys just, kind of work in a little bit more, but primarily, we get paid by the patient. And so you just can't go any faster. Newsweek's article this week notes a 28% increase in the average primary care physician's panel size in the last 20 years. So this is a new method of practice. I mean, this is not business as usual. There's a whole bunch of stuff that is proven to be better. You can read about this. Revenue goes up under this model, even if insurance companies don't take into account that you need to be paid for some of this prevention and care coordination you're doing. Now, what the insurance companies are talking about now is they will actually pay you per patient per month for this stuff that you do outside the office. Right now it's all office visit. Everything has to be done in the office visit. Reduced ER utilization, Director Moody talked about that. We talked about readmission rate. And so what we're trying to get away from is this not see more patients model. One thing I want to throw in here, the electronic health record part of it, I think is very important. I don't think you can do patients are going to go home without electronic records. I've studied it, looked at it. There's places that have done it. It just can't be done. I have patients who walk into the office for an appointment. I mean, not for their appointment, to make an appointment. Okay, that's, we tell them, we go over, show them this thing called the telephone. Okay? And you can call, and we will help you. But I have patients that pay their utility bills at the bank. Okay, they actually go to the bank and pay their bills. And so when you look at that, that variety of, the new medical use rules are talking about kiosks in the waiting room so patients can check their records. We just hope they get there on time would be good. So it's going to take some work to get that all coordinated. There's just a wide range of patient ability and physician and practice. I don't want to just put it all on the patient side. It's on our side too. I'm entering lab data in a paper flow sheet in my office. I have medical students that are like, here, watch this. Okay, I am writing their LDL right here. And they just look at me. I said, trust me, 20 years from now, you'll be able to talk about this. So anyway, so we need improved outcomes, reduced costs, enhanced reimbursement, increased physician and staff satisfaction. I think it would lead to increased patient satisfaction. This is not a new concept. This goes back to the 60s. Pediatric Society was actually the original guru on this. But these are the 4 societies in primary care that have bought into this. But you can read. It's a team approach. I think the best way to look at it is it's coordinated care. Okay, this is not piecemeal. Catch as catch can. We've got to work this into your appointment for your need because you're due for your lab, and then we get paid for it. The physicians, nurse practitioners, it could be PAs leading the team, but it's going to be a team approach. I got to change this slide. The word nutritionist is bad. Dietitians, stroke out. Is there any before I say this? Is there any dietitians in the room? That's not. Oh, is there? Yeah, that's okay. Is that right? That's not the word. Yeah, there you go. Ooh. Okay, sorry. Okay, so you see the list, and with the patient at the center, we talked about that. The patient becomes the center of this whole deal, and how does the patient want to be seen? There's different ways to e-visits. Trying to figure that out with the patient who walks in to make their appointment. Okay, got to do an that's for Ecklar, is what they say. Oh, that means Dr. Ecklar. No, it's not that. But group visits, schedule opened up so you can see. It's much easier to see people the day they call. They're much more focused on what's wrong with them. So that's another concept. These are some of the things that we stink at right now. If you look at the data, we try. I'm doing the best I can under the circumstances. But these are all things that firearm safety is on the list of one insurance company that I counsel a patient without firearms. I have to note that. I think the electronic record covers that. Seatbelt use was another. It's just don't drink the toner. That's my latest. But all these screens, and I don't want to this stuff's important. I mean, this stuff's important. We just can't lose enough time to do it. Under the current, see more patients, a treadmill. And you can read this. These are the areas that the MCQA has picked out that you need to, and there's all kinds of things you have to demonstrate about access, patient engagement, your information system, care coordination, team care, patient feedback. One thing I want to throw in, and then I'm going to move to House Bill 198 real briefly. I worry about the patient engagement part of this, okay? I don't know that everybody, someone who was 1 year late for their colonoscopy, that's me. It's just people don't, it was okay, I know you're worried. But I just worry about how, patient engagement, and I think we can do a better job of directing and leading people and coordinating their care, but I just see a lot of people that just every year have gained 2 or 3 pounds. I mean, just on and on. It's just that part worries me. And there's plenty of outcome studies that say this works. I'm not going to go through them. Money saved, less ER utilization, which is why the insurance companies are interested in it. I mean, there's I tour medical students that come to Mount Carmel for their rotation. We stop in the emergency room. I like to give the docs crap for what they're following. And so I'll have them pull up their list. And the students are just expecting, pneumothorax, cardiac arrest. How about diarrhea for 20 years? Okay, in the emergency room, I wanted to violate that, but go to the bedside and go, I just got to ask, I'll probably get fired for this. Why today? In an emergency room. I mean, $1,500 minimum. I mean, just, I tell patients, I'll see you for $750. Just half that, and the weight is less. So anyway, one of the models here is an airliner. The pilot needs to do the pilot stuff. Okay, I was a clerk in the lost baggage section the other day. Okay, but everybody needs to be working at the top of their license. I mean, that's kind of the theory behind this, and I know some of you have heard it. And these are the standards. Okay, I'm not going into that. Here's the deal with House Bill 198. Came out of the Dayton area. Dr. Winslow and Peggy Lehner, that was the senator that was involved in this. 4 regions of the state picked out for primary care, patient-centered medical home focus. The Cincinnati, Columbus, Dayton, and Cleveland were left out on purpose because they are ahead of the curve on this. Here in Columbus, it's Access Health Columbus has helped with about 30 practices, to transform. And so 11 practices in these 4 other parts of the state: Dayton, Toledo, Akron, Canton, Athens. None of this is in the handout. 11 practices per each area. At least 4 of them had to be nurse practitioner led, and at least 6 of them had to be rural. 69 applicants, 44 were picked. So the practice has been picked, ready. Only 1 has dropped out, waiting on funding. So the idea is to get these practices transformation help to move over to this model. Medicaid recently came up with $1 million, so we now have funding for these. The estimate is about $20,000 per practice. 6 more practices are going to have to make 50. So those are the practices. The thing that's different about this bill, there's an educational component, actually a curriculum that's been written to teach patient-centered medical homes for the 4 medical schools that are in those areas, and the 5 nursing schools: Wright State, Toledo, OU, and then Kent and Akron are both in the neo-med system. So there's curriculum that's been written. Ohio State has adopted it already, since I'm on the curriculum committee for the longitudinal preceptorship that 1st and 2nd years. Ohio State took this and went, oh yeah, this looks good, and adapted it right away. So neo-med is adapting it, and Wright State is going to adapt it. So there's an education piece. Students will then work in these practices. And so the hope is that to generate more interest in primary care. Here's the big deal with this: there's scholarship money. The biggest thing hanging over medical students and nursing students right now is how much they owe. I graduated from medical school in 1975 with $7,500 worth of debt. I should have borrowed $1 million, okay? And when money markets were paying like 15% in '81, I would not be worrying about whether Medicare is going to go away in 2024. Okay, so they the average $150,000, $180,000, and the debt load is just hangs over their career choice. So there's $3 million worth of scholarship money for nursing scholarships and medical student. Now we're supposed to go to the appropriations. Well, I'm learning all this stuff about state government. Appropriations Board met Monday. It got bumped to the May 7th meeting, so that hasn't been formally approved. The medical schools are ready to send out the money. So these will be scholarships for second, third, and fourth year medical students of significant amount, $30,000 to $50,000. We're not talking about bookstore money. We're talking about, solid money. And the idea is you got to do your residency in Ohio, which will be 3 to 4 years, and you have to practice in Ohio for at least 3 years, but that will eventually go to 5. So that's the deal with House Bill 198. We're trying to get other money for transformation help. Practices have been selected. Scholarship money is available. The Board of Regents has it ready to go as part of Choose Ohio First program. This is an offset of that offshoot. So that was what I wanted to get over about the Patient Centered Medical Home. Exciting concept. Something's got to be done. Students need to see physicians feeling like they're, and nurse practitioners and PAs feeling like they're accomplishing what they went to school for.